This video will focus on the physics of magnetic susceptibility-weighted imaging, or SWI, for neuroradiology residents. SWI is crucial clinically for detecting up to 6 times more microbleeds than other sequences, helping with stroke and TBI management. It helps distinguish calcium from hemorrhage using phase information, providing CT-level confidence on MR. Additionally, SWI offers a high-resolution, non-contrast intracranial venogram. Magnetic susceptibility, symbolized by Chi, measures how tissue magnetizes in the magnetic field B0. Paramagnetic materials like iron-containing blood products concentrate the field, giving a positive Chi. Diamagnetic materials like calcium exclude the field, resulting in a negative Chi. Ferromagnetic materials cause severe blooming due to a very large positive Chi. The blooming artifact is exaggerated signal loss, extending beyond the lesion due to local field inhomogeneity and intravoxel dephasing. This effect is maximized in SWI using long echo times, high field strength, and small voxels. While it causes false enlargement of small bleeds, it provides unmatched sensitivity to microhemorrhage and venous deoxy-HB. An SWI image is built from a 3D GRE acquisition that yields a magnitude image and a raw phase image. The raw phase is filtered to remove background noise and B0 drift, creating a phase mask. This phase mask is multiplied by the magnitude image, typically 4 times, to generate the final SWI image. Always interpret both the magnitude and phase images, never SWI alone. Phase is determined by the Larmor equation, phi equals negative gamma times delta B times TE. Raw phase is acquired between negative pi and positive pi, resulting in a striped or wrapped appearance. A high-pass filter removes slow B0 drift. The filtered phase separates paramagnetic and diamagnetic substances, with the sign depending on vendor-handedness. Vendor-handedness determines whether paramagnetic substances appear bright or dark on the phase image. Siemens and Canon are left-handed, showing paramagnetic substances as bright. GE and Philips are right-handed, showing paramagnetic substances as dark. A universal safety check is to identify the internal cerebral vein and the pineal calcification to confirm the local convention. To distinguish hemorrhage from calcium, examine the SWI magnitude for hypointensity. Then, use the phase image to determine if it is paramagnetic hemorrhage or diamagnetic calcium, based on your scanner's handedness. Always cross-check with CT, where hyperdense lesions with blooming on SWI are blood. Cerebral microbleeds, or CMBs, are round, hypointense foci. Their distribution is key to diagnosis. Lobar suggests cerebral amyloid angiopathy, deep suggests hypertensive microangiopathy, and mix suggests mixed small vessel disease. Cavernomas, or CCMs, have a classic popcorn appearance with a hemosiderin rim. SWI is critical for detecting small cavernomas. The take-home is to distinguish between these based on distribution, morphology, and patient history. Diffuse axonal injury, or DI, shows punctate or linear hemorrhagic shear foci. SWI detects 4 to 6 times more shear foci than GRE, upstaging injury severity and predicting outcome. Venous thrombosis appears as an expanded, dramatically hypointense sinus or cortical vein because the clot is paramagnetic. SWI directly visualizes these thrombi and should be added to trauma and suspected CVT protocols. Several pitfalls exist with SWI. Hyperacute hematoma can be missed in the first hours because of pre-deoxygenation. Late subacute blood can appear bright due to T1 shine-through. Susceptibility blackout near the skull base can mimic blood. Calcium can show paradoxical phase contrast, and phase aliasing can occur with large lesions, making phase interpretation ambiguous. Grayscale inversion is a common workstation default that must be checked against a known vein or pineal calcium. For reporting, always open both magnitude and phase images, as phase is vital for separating blood and calcium. Know your vendor-handedness before signing out. Quote the distribution of microbleeds, not just the count, to guide clinical decisions. Mention the blooming artifact when measuring lesions, and in trauma, scan SWI on every TBI study, as GRE underestimates DI severity. The teaching nugget to remember is always, identify the vein before you call the bleed. Your internal cerebral vein is the reference standard for paramagnetic signal on every SWI study. Anchor handedness first, then interpret your images.